Welcome to the Explainer. Lysosomal storage diseases can be a really daunting topic for your board exams. So today, we're going to break them down into a clear, high-yield framework that's actually going to stick. Okay, so here's our game plan. We'll start with the basics, what a lysosome actually does. Then, we're going to use Gaucher disease as our perfect model to understand what happens when things go wrong. After that, we'll tackle the big one, the sphingolipidosis, comparing them side by side. We'll touch on a couple of other key disorders, and then we'll wrap it all up with a quick review to make sure it all sinks in. So first things first, let's build our foundation. What exactly is a lysosome? And what happens when the cell's little recycling center just breaks down? Right. Here's the most important point to get. Lysosomal storage diseases are all about one thing, accumulation. You've got a faulty enzyme in the lysosome, which means its specific target, its substrate, can't get broken down. So what happens? It just builds up and up and up inside the cell, eventually causing all the problems we see clinically. So how does the system actually fail? Well, to really get the core mechanism, we're going to use Gaucher disease as our case study. It is the perfect example of what happens when the enzymes don't even get delivered to the right address in the first place. So picture this clinical scenario. This is an absolute classic for Gaucher disease, which you might also see called mucopolysaccharosis 2. When you see a little baby with this specific set of symptoms, the coarse facial features, the skeletal problems like dislocated hips, and getting sick all the time, your brain should immediately jump to a major, system-wide lysosomal problem. Okay, to get what's wrong, we have to look at how it's supposed to work. So a lysosomal enzyme gets made in the ER. Then it travels over to the Golgi. Now, in the Golgi, this really important enzyme, N-acetylglucosine-1 phosphotransferase, slaps a phosphate onto a mannose residue. This creates what's called a mannose 6-phosphate tag, or M6P. Just think of this M6P tag as a molecular zip code that basically tells the cell, hey, this package needs to go to the lysosome. Now, in Gaucher disease, the whole problem is that the tagging enzyme itself, that phospholysotransferase, is broken. So the lysosomal enzymes never get their M6P zip code. And without that tag, the cell has no idea where they're supposed to go, so it just defaults to shipping them outside the cell. The enzymes are perfectly fine, they're just sent to completely the wrong address. And this leads to the absolute classic finding you need to know for diagnosis. If you take some of a patient's cells, say fibroblasts, and culture them, you'll find super low levels of lysosomal enzymes inside the cells because they've all been kicked out. But if you test the liquid outside the cells, you find sky-high levels of those exact same enzymes. It's a dead giveaway for this trafficking defect. All right, now let's get into the heavy hitters. We're going to tackle the biggest and most tested group of LSDs, the sphingolipidosis. And trust me, the best way to learn these is not one by one, but by putting them head-to-head and comparing them. This chart is your best friend. It has pretty much everything you need to know, all in one spot. For each of these, the goal is to connect the dots, from the missing enzyme to the stuff that builds up to the key clinical signs. So for example, look at Tay-Sachs. No hexosaminidase A means ganglioside GM2 builds up, causing that awful neurodegeneration. Now compare that to Gaucher. No glucocerebrosidase means glucocerebroside builds up, leading to bone problems and those famous crumpled paper cells. We're going to really focus in on these differences. Okay, this right here is probably one of the most classic board questions you will ever see. Both Tay-Sachs and Niemann-Pick can show up with that cherry red spot on the macula and serious neurodegeneration. So how in the world do you tell them apart? It all comes down to the physical exam. Tay-Sachs does not have an enlarged liver and spleen. Niemann-Pick does. That is the critical difference. You have to know it. And here's a great little mnemonic to make sure you never forget the enzyme for Tay-Sachs. The hint is right there in the name. Tay-Sachs lacks hexosaminidase A. See it? It's a perfect way to lock that connection in your brain. Now for Gaucher disease, which happens to be the most common LSD, I want you to think about three things: big spleen, bad bones, and weird cells. Patients get this massive hepatosplenomegaly, which can mess up their blood counts. They get these really painful bone crises and fractures. And of course, the absolute hallmark finding on a slide is the Gaucher cell. A macrophage just stuffed with glucocerebrosidase so it looks like crumpled tissue paper. Okay, time for a super important, super high yield exception. When you think about inheritance for LSDs, just remember this. Almost all of them are autosomal recessive. But there's one major outlier you have to know, Fabry disease. It's X-linked. I promise you. If a test question mentions inheritance, your first thought should be Fabry. All right, we've made it through the sphingolipidosis.
let's just quickly round things out by hitting on a few other really important storage disorders that don't quite fit in that category.
Here is another classic comparison you gotta know. So Hurler syndrome is a mucopolysaccharidosis, and Pompe is a glycogen storage disease. But they're both LSDs, so what's the key difference? For Hurler syndrome, the classic finding is corneal clouding. Their eyes look cloudy. For Pompe disease, you have to think about the heart. These poor babies have a massively enlarged heart, cardiomegaly, which is usually what kills them. So remember, Hurler, cloudy eyes. Pompe, big heart.
And last but not least, we have Chidiac-Higashi syndrome. This one is really unique because the main problem isn't a faulty metabolic enzyme. It's a defect in the LYST gene, which messes up microtubule polymerization. This trafficking issue leads to a classic triad: recurrent infections, partial albinism, and nerve problems. And the key thing you'll see under a microscope is giant granules inside their neutrophils.
Okay, wow, we have covered a massive amount of information. So let's pull it all together and do a quick fire review to make sure these ideas are really locked in for test day. Here it is. This is your final cheat sheet. If you can only remember one key thing for each of these diseases, make it this. I cell, lost enzymes. Tay-Sachs versus Niemann-Pick, check the spleen. Gaucher, crumpled paper cells. Fabry, it's X-linked. Hurler, cloudy corneas, and Pompe, that huge heart. Okay, question 1. Let's think this through. You see a triad of nerve pain, these specific skin spots called angiokeratomas, and kidney problems. That is classic Fabry disease. And what is the one single genetic fact you need to know about Fabry? Right, it's our big exception, X-linked recessive. Question 2. As soon as you see the words crumpled tissue paper, that is the absolute buzzword for Gaucher disease. That look comes from all the glucocerebrosidase that's built up. So the enzyme that must be deficient is glucocerebrosidase. Simple as that. All right, this one's testing that key differentiator again, but in a tricky way. We have a cherry red spot and a big spleen. We know Niemann-Pick has both of those things. But Tay-Sachs has the cherry red spot without the big spleen. So this presentation is not consistent with Tay-Sachs disease. And for our last question, we're coming full circle. Why do all those enzymes end up outside the cell in I cell disease? It's all about a failure of tagging. The cell never puts on that mannose 6-phosphate zip code until the whole delivery system just completely breaks down. If you can understand that one mechanism, you're well on your way to understanding all of these diseases. And that's our explanation on lysosomal storage diseases.